Here. Wow, what a powerful morning we've had. I was really so inspired by this morning's presentation and speakers. I've always suggested that this is one of the most interesting times to be in medicine, and it's just really inspiring to be surrounded by all these amazing people who are the ones who are actually making the change. I want to thank Kirsten again for pulling together this amazing event. The irony here is that I'm being led into the future by an English professor, if that gives you any idea of how things are. But going forward into our next panel of speakers, we're starting off with Into the Eye of the Storm with Stacey Chang, who's perfect for that title because he is truly in the eye of the storm at the new Dell Medical School. He's the executive director of the Design Institute for Health. And a lot of what we've heard this morning around education is being led by the hard work of Stacey. So we're excited to have you.
Thank you, Brian.
Yeah.
I would say don't clap until afterwards because you don't know what you'll get. So in the same vein, I'm very much an unintentional academic. I'm an engineer by training. I never thought I would be a professor in a university. Much to my parents' chagrin, immigrant parents who thought, oh, my son should be a professor. And so a lot of this is about the story of what happens when an engineer, an entrepreneur, and a commercial consultant ends up in an academic environment that gives us a lot of opportunity to actually do different things. So I'm going to tell you a little bit about the genesis of the Medical School and Design Institute because those circumstances are actually pretty important to the story, and then share with you some of the work that we're doing. I won't have nearly enough time to go into any level of detail for any of those, so we'll save the Q&A for anything you want to hear more about. So it's really lovely to be speaking to an audience like this because I don't have to waste any slides sharing with you, sort of the state of the U.S. healthcare system, how we spend, twice as much and get third of the good as an outcome as all the other industrialized countries. I also don't have to show you the slide of where we land on the WHO list in terms of health outcomes, somewhere between Costa Rica and Cuba. And I also don't have to invoke Steve Jobs in explaining that design is not just about aesthetics. So I won't show you any of those slides. But I'll start with the question, which is, what is the role of design in health? And this question has been pervasive in my life. And it began with my parents who thought, as an engineer, I'd go pursue some career at some large Fortune 500 manufacturing company, and that would be the extent of my life. Instead, they're really disappointed because mostly they can't explain to their friends what their son does. And so much of my worldview has been shaped by a company called IDEO, and you're going to hear from the Godfather soon. I've spent 12 of my 25-year career in and out of the firm. I think I hold the record for most times in and out, all willingly. And I was the first intern in the Boston office some 25 years ago, so yeah, I am that old. But when I was at IDEO, I would answer this question by explaining the work that we did, right? And the work we did was, designing hospitals for Cleveland Clinic in Abu Dhabi, designing innovation centers for Mayo Clinic, helping Nike with strategies to keep people active so they could sell them more shoes and clothes, designing the interfaces for the health insurance exchanges that the feds eventually adopted after their disastrous launch, or the legacy of IDEO, which was around, what I did when I first joined was design medical devices. That's how I entered the healthcare field. And that was the answer I would give. But the problem was there's always this little unsettling aspect of the work that I was doing, which was I was really working at the edges of the dysfunction, right? I was getting an opportunity, and it was fantastically interesting, a really fantastic antidote for someone with ADD to actually work on all these different projects serially over the course of a career at IDEO. But I realized at some point that I wasn't getting to the grand effect that I had hoped for, which was actually changing the healthcare system itself utilizing design. And so that was a little unsettling. And so about a week and a half after I left IDEO in 2014, I got this call, and this was the system that's so broken. I got this call from who was a client of mine and then became a friend, and then more recently had become the dean of a new medical school in Austin. His name was Clay Johnston. He called me and he said, hey, there's really remarkable circumstances in Austin that gives us a chance to essentially design a modern version of a healthcare system in the U.S. And I've got all these, clinicians and academics and usual suspects, researchers and the like. But if we're really trying to design a new healthcare system, I actually need designers. Would you be interested in coming and lending your efforts to the cause? And I was like, that sounds ridiculous. I'll come down and chat with you. At best, I'll consult with you. And then 3 months later, we announced the Design Institute. So we just celebrated our 3-year anniversary, which is bananas because it feels like 4 months. But it's actually worth telling you a little bit about the circumstances in Austin that gave rise to this opportunity. So back in 2012, and I have to tell you, Texas is #1 on a lot of lists, but it doesn't want to be #1 on this list, which is we have the largest percentage and number of uninsured individuals of any state in the country, and it's at 18%. We rejected the expansion of Medicaid, and so you have a large population. It's actually much larger than 18% because a lot of people choose not to be identified, that are uninsured, and they don't have health insurance. And this statistic is true in most urban centers. For Austin, the 200 people who cost the city the most in unreimbursed healthcare expenses each year cost the city, on average, $200,000 each. Just $40 million just for those 200 people of money that's essentially wasted in a very bad version of socialized healthcare system, which is we take care of you only when you show up at the ER. And so you could feed, house, entertain, train, reintegrate with society, care for any one of those individuals for far less than $200,000 a year. And it was that economic argument in 2012 which led to the passing of a ballot measure whereby the residents of Travis County voted to raise their portion of their property taxes dedicated to health care for the poor, to raise it by 63%, which is crazy. Like, no one raises taxes that way, certainly not in Texas. But if you understand Austin, it's not really Texas. So that was the basis actually for a really remarkable effort. One was to develop a new county hospital. The county hospital was some 40 years old, really decrepit, really needed a rebuild. That was then brought online about a year and a half ago, the spring of 2017. But also a new medical school. And it was the first medical school in almost 50 years at a Tier 1 academic research university. And what's unique about that is what most academic medical centers won't tell you about at dinner parties is that they're in some ways complicit in the dysfunction of the U.S. healthcare system, right? They have 3 missions. They have teaching and they have research. Neither of those make money, so they depend on their clinical enterprises, their care enterprises, to actually fund the other 2 missions. And so they're incentivized to actually build huge hospitals and use specialist procedures actually to treat and then therefore fund treat patients and then fund their other missions. Now, I don't blame the hospitals or the physicians for doing that. They're essentially responding to the system's incentives. We actually have to change the system's incentives for that to shift. But we had an opportunity to disavow that. So we didn't have any legacy. We weren't beholden to it. The dean actively disavowed any fee-for-service models in the work that we would do, and so we're a strictly value-based care model, and we're in pursuit of that. And because we're funded by the community, we actually owe the community a return on investment. So they paid for it. They're expecting better health. Not health care, necessarily. They're expecting some of that, but they're also expecting better health. And so the most remarkable part of this is that most of that money, or rather all of it, went to a local payer. So the Travis County Healthcare District, known as Central Health, actually pays for care for those who don't have health insurance. There's a program called MAP. It's called the Medical Access Program. And it's essentially health care services and insurance for people who can't afford it, right, addressing the very economic burden that I just described. And their interest is actually moving away from fee-for-service too, because they know that doesn't have an appropriate outcome. And so they force the local FQs and other providers to actually abide by new models of care that are value-based because they pay for that kind of service only. So that gave us a really unique, essentially closed feedback loop where we could define new models of care, deliver them, test them, see if they worked, measure them, and then if they didn't, to adjust them, because we're both the payer and the deliverer of care as a region. And we actually cared about a systemic model of care because we essentially were paying for all of that. So I got then invited by the 2 deans, one from the from the School of Medicine and the college, and the other one from the College of Fine Arts, where design is housed at UT, to establish the Design Institute for Health. And you actually have to channel these 2 deans in order to understand why we exist. The first is the medical school dean says, hey, look, actually, the role of medical schools is actually to respond to the demands of society and what they want out of health and healthcare. And the College of Fine Arts scene recognizes that actually creative disciplines have a role in solving really complex systemic problems in ways that our traditional science-based and evidence-based approaches have not figured out. So we exist here, in between these 2 schools. And oddly, I'm a full professor in 2 schools for which I have no degrees, which is a little daunting sometimes. So I'm going to put all these up, and these are, I explained some of these already, and I'll get into a couple more of them in a second. But really, the point here is we have an opportunity in Travis County to actually take a very systemic approach to actually redesigning health and healthcare. And that's, the notion of once in a lifetime gets sort of bandied about too often, but for us, it's actually true. Like, there are a number of levers that other places don't have that give us a chance to actually build from the ground up a lot of the approaches to solving society's health problems. One of them is the payer we talked about. Under the umbrella of large-scale payment reform at the national level, right? CMS is moving 80% of its reimbursement models to have some value-based component by the end of this year. That's remarkable. And I always say you can't have healthcare reform unless you have payment reform. If you don't change the financial incentives, the system won't respond, and we have that as an umbrella, even more so locally. I'd say one of the most interesting things about being in Austin is that it's already an incredibly entrepreneurial city. And we will not succeed in our endeavor in Central Texas unless we actually turn Austin into the center for health entrepreneurship. Not healthcare entrepreneurship, that might be Boston or Silicon Valley, but in health entrepreneurship and how we keep and make and keep people healthy, not save them when they get sick. So the design student is actually pretty intentional about the things that we work on. I'm going to share with you 4 trajectories that we're focused on in the near term. And this is all the hand waving before I give you the tangible examples, so bear with me. We believe one really important thing we have to do is actually move the system from what is a physician-led system to one that's actually more self-enabled. The goal is not to disrupt the physicians out of the system. They're critically important, but actually to move it closer to being more self-enabled. And the reason for that is, the diseases we face now as a modern society are really diseases of a social nature. It's very, very different than the diseases we faced 2 generations ago. We used to die from acute infection or trauma. Like, we've mostly solved that through the advancement of medical science and technology, right? Vaccinations and, our ability to keep people from dying when they've been hurt. The kind of diseases we face now are things like diabetes and hypertension and obesity. They are consequences of the way we live, of our behavior, of our circumstances, of our education or race or gender, all the social determinants we talk about. You don't solve diabetes, as evidenced by our previous speaker, in a once every 6 months clinical visit. It just doesn't happen. Right? It has to happen in behavior change and literacy and engagement and empowerment. And so those are things that more likely than not, reside with the individual. And so we have to get them to more engaged. We have to move the experiences from ones that are very transactional to ones that are more human-centered. And the transactions happen because that's how healthcare is reimbursed right now, every billable encounter, right? You've heard that before. I love the notion of an RVU. It cracks me up, right? Like, none of my physician colleagues recognizes what a ridiculous notion that is. RVUs are units that have no basis in actual reality. And they're not even absolute units, they're relative ones, right? And they spend their entire lives chasing a relative, non-absolute, measure that doesn't actually exist in real life. I was like, does the irony strike you as funny? They don't laugh at me. But our goal is actually to move from transaction to human-centered, and the reason is this. It's a little bit philosophical, but real healthcare value is delivered in the human transaction between someone who cares and someone who needs to be cared for, right? The reason the doctor carrying the black bag in your community, in the 60s had an effect is not because what they had in the black bag was actually effective on your disease. It's because they had a trusting relationship. They were part of your community, and you could actually develop ways for them to actually move against the disease based on a trusting relationship. We've managed to actually completely, in most cases, eliminate that opportunity in our modern healthcare system. And part of our goal is actually to return that relationship to the center of what healthcare is in trying to do. It's very siloed, not at all integrated, and there are competitive reasons for that. I'll talk about that in a second. And then this one, which is, you all know, right? Any one of your individual health outcomes as a person, only 11% of it, roughly, is due to your access and the quality of your medical care. Like, our advancement in medicine actually has reduced that as a contributor to your health. All the other things are the things that we have to address. And our belief is that you can only do this inside an adaptive, responsive health system. No health system has ever been described that way, right? And so part of our job is actually building a health system that actually can be adaptive and responsive, and that's the role that design has to play. So So we practice lots of design. The things at the top of the list are things that most people are familiar with when they think about designers. The things at the bottom are places where we get to break new ground. And so we're actually designing systems, organizations, cultures. Those are actually critically important when you're trying to change a system. The things at the top are affordances that allow the system to operate the way you intend, but actually in order to get the system to operate that way, you actually have to work on the things at the bottom. So when I get asked this question now, my answer is actually really, really different. It's not examples of the work that we did at IDEO necessarily, even those are important and impressive. But my response now is actually the role of design in health is actually just to provoke change. Like, we have an opportunity to provoke change, and it's actually change that's the critical challenge for the healthcare system. Why is it the last one to respond to design? Because it's really reticent to change, and there are a lot of inbuilt incentives that keep it from changing. And so I'm going to give you examples in different venues of where we're trying to provoke change. In some cases they're succeeding, in some cases they're still trying. So in systems, we provoke change by characterizing the uncharacterized. What I mean by that is when we showed up in town 3 years ago, we asked, hey, who knows how care is funded and delivered in this county as a whole? How does the system work? Nobody, literally nobody, could answer that question. Everybody had a tiny view of their sliver of funding or care delivery, but nobody could answer that question in totality. And eventually people sort of shuffled, looking at the shoes, said, well, maybe you could build a map. And we said, all right, we'll do that. Right? And designers, our point of view is how can you redesign a system if you don't know how to operate, right? Healthcare is the only industry that doesn't actually know where its costs are, right? It's bananas. It's totally crazy. So we built this map. And what you can't see is the subheading for that map. It's in tiny words. Says, a necessarily incomplete, possibly inaccurate, but urgently needed map of health delivery in Travis County. We have this hanging up in the wall in our design studio. It'll actually go online in about a month. And this is actually a shaming mechanism. Thanks. And so everybody who's from the region stops and takes a picture of it. It's like, I've never seen this before. Everyone who's not from the area stops and takes a picture of it and says, I wish I had this for my region. In collaboration, we call out the really uncomfortable truths. So we've been working on this thing called health management. It's a neuter term, which means exactly nothing for political reasons. But it really is about systemic care coordination, right? And we've called out 9 collisions where the system behaves one way in opposition to the way that actually patients and physicians want the system to operate. And I can go into a lot of detail. We can talk about this in questions if you're interested. In clinical practice, to actually shift the power dynamic, if we're really going to enable patients, we actually have to give them more control over their experience. And this is, I was threatening the architects in the room with this story, and I'm going to share it. We inherited this building when we arrived, before the dean had declared that we were going to disavow fee-for-service. And we inherited this building for a medical office building. It was designed for specialty clinics and designed perfectly for fee-for-service. It was at all these little coffin-type rooms where you jam a bunch of people in for serial encounters, try to get them back 6 times in 3 months so you could actually bill a lot. And the dean said, no, actually, that's not what we're doing. And frankly, I have these designers who've done some of this work before and told the architects, hey, maybe they could offload some of your work. And the architects were like, hey, fantastic. And they said, yeah, bring them on. And they've regretted that decision ever since. I remember the first meeting. The architects were like, they opened this giant binder, and they said, oh, we've designed 15 of these in the last 5 years. Here's all the specifications for best practices. And it's 9% of every floor plate is dedicated to a waiting room. Where do you want yours? And we said, I don't think anybody wants a waiting room. I've never met a patient who's happier for having been stuck in a gray box with other sick people and Jerry Springer for 30 minutes. I'm pretty sure nobody wants a waiting room. So let's see if we can figure that out. And they're like, no, you have to have a waiting room. We're like, otherwise, where are you going to get your ready supply of ill patients who you can bill against? And I said, well, actually, and Toyota does just-in-time manufacturing. They don't warehouse their stuff either. We don't have to warehouse patients. And so we design clinics that don't have waiting rooms. And there's some really interesting consequences, some really interesting fistfights that break out between you and the clinicians. And, I even had a clinician try to pay off facilities and create a waiting room out of one of the exam rooms. The benefit was I'd actually paid off facilities first. So this is the entry hallway to our medical clinic, which looks nothing like a traditional medical clinic. The CTO of HHS came and visited. He's like, I'm really disoriented. I've been trained to understand how to navigate a traditional medical clinic. I don't even know where to go in here. And it's like, yeah. We'll talk about that. So in technology, our view of technology is actually to return the primacy of the human relationship between the patient and the provider to the center of the experience. And so we have this thing called the exam room of the future, where it's actually a catch-all for actually doing really interesting explorations in technology. We just launched a startup with an MIT spin-out, got accepted to the Phillips Accelerator up in Boston. We're using voice recognition to capture the conversation that's happening in the exam room and autofill most of the fields in the EHR, so that the physician only has to correct anything that wasn't correct, but actually can focus all of their attention on the patient and not spend 40% of their time with their back to the patient trying to type away at something the EHR wants out of the visit. In community, to embrace the taboo, there's a really unfortunate circumstance in Austin where back in the 40s they drew a dividing line in the city and pushed all of the people of color to one side. If you look 70 years later, that still persists. To its credit, Austin has been trying to overcome that now for a couple generations. But the outcome is that usually what happens is those neighborhoods then get gentrified, which is what's happening now, and then people get pushed out, and the soul of the city is lost. So we're actually working. This is a really colorful map that actually shows the emotions of the city. A really interesting artist, digital artist in Austin, created this, and you can map the inequity directly to the emotions of the city as well. And so we've been actually deploying new experiments in the community about how you have a conversation around healthcare, which nobody wants to have, by beginning with a conversation around social connection and arts and food and all the sorts of things that we love to have conversations about, but actually really are just conversations around healthcare. So we have the opportunity to actually build, like real estate build, 2 developments that actually imbue clinical, research, commercial, residential, and all those aspects to try to create health as an outcome of a community in ways that you can't achieve in clinical environments. And then in mental health, to remake the model, designers never get a chance to do this. So it's been remarkable. About a year ago, the Texas legislature was about to spend $200 million rebuilding the Austin State Hospital, which is the institution of last resort when you get committed as a mental health patient, right? It's actually more of an outcome of the criminal justice system than it is of the healthcare system. They were going to spend $200 million rebuilding a concrete building from 80 years ago with padded rooms, and our response was, that's not actually a model for modern mental health. And so they came to their senses, remarkably. And my co-founder and the head of psychiatry at our medical school are leading a planning grant, about $20 million of work, to actually decide what the mental health model should look like for 39 counties in Texas that actually treat adults, and then 64 counties, which is about a quarter of the state, for adolescents. So we're actually currently building the new model for what mental health treatment should be, and I guarantee you it's not a concrete building with padded rooms. So, and then last is what you might expect of someone working in a med school, is actually we're educating patients. And so our students are actually unusual in a lot of ways. The thing that we succeeded in doing with the accreditation agencies was actually changing the dynamic of the 4 years of medical school. So normally it's 2 years of classroom learning, then clinical rotations in the 3rd year, and then specialty rotations and prep for your internship and residency in the 4th year. We managed to convince them we can jam all the book learning into the 1st year, clinical rotations into the 2nd, and we'd free up your 3rd year for whatever you wanted, including a 1-year MBA, a 1-year MPH, a 1-year degree in biomedical engineering, or focus in design. So they have an entire year to choose one of those tracks. They can do lab research or community research. We offered up design, and 28 of the 50 students says, we want to do design. We're like, whoa, no, we can't take that many. So we actually threatened them that it'd be really hard and they'd be guinea pigs, so we were down to 9, which is manageable. Starting next year, actually, it will be a 1-year degree granting master's degree in design in healthcare. It will be the first degree that we know of on that front. But what it allows them to do is actually develop skills alongside their clinical skills for the future leaders in medicine, right? So they can take on organizational design, business model design, they can do service design, they can do storytelling, they can do campaign design. And so we actually cross-register them with classes in the rest of UT Austin, and they can take things. People who are doing storytelling can take documentary making in the School of Radio, Film, and Television, right? And so really remarkable benefit for being part of such a large research campus. So I'm going to stop there and just end with this provocation, which is we all know healthcare is reluctant to change, and our role as designers is essentially to provoke it. So how will you? Thank you.
So I'll just ask the question that I think a lot of people just had in their head at that last second. So are other people other than Dell medical students going to be able to do your health design masters?
Yeah, actually, it's an interesting response to actually some demand, a lot of demand we've seen. We didn't want it, like when we joined the university, we said we're not actually going to teach, and then a pile of students said, no, you actually have to teach. So it's a class originally built for the medical students, but actually the registration for it is going to be overwhelmingly from students outside of the medical school who actually want to focus in healthcare design, including Matt.
To change healthcare and health, I think these ideas will come in because of just they have an enormous amount of face validity, and people get incredibly excited about it, and they use these tools. But another part of this change, at least in academic medicine and probably more broadly, is going to be generating persuasive evidence.
Yeah.
And that's typically, you know what I mean.
Yeah, absolutely.
The traditional kind that regulators and payers and overseers acknowledge as saying, okay, you've proven that it's making a difference now.
Yeah.
We're gonna, So what are your thoughts about where these ideas that you have can be introduced into health services research, clinical research, or wherever, to start generating some evidence for the skeptics or for just what's necessary to really evaluate how well this is working out?
Yeah, it's a fantastic question. We were talking about it earlier, and one of the challenges facing design, and The Godfather gets to address this later, but is how you actually make. Dennis is hating this. Like, well, you are all going to call him The Godfather the rest of the day. It's really challenging, and it's akin to the question that gets asked all the time in commercial environments, which is like, well, how does that one marketing intervention change the uptake of your product service offering, right? And like the answer is hard to tell, right? But in totality, we know it works. In the same way, like as individuals, there's no doubt that a quality designed experience. You compare the Apple iPod to the Microsoft Zune. There's an example I gave earlier. No one remembers the Zune. Everyone knows the iPod. And it was about design of all those experiences. As individuals, we know that it's better, and we're more likely to engage. Now, then the question is, how do you actually measure that? And it's hard to measure individually. Assigning a definitive ROI to any design intervention is hard to distinguish out of the totality of the whole offer. And so while we are studying that, actually, and that's actually a particular R&D project of ours, the other way to do it is actually to bundle it with the totality of the experience. And so what we've done with our commercial insurance providers has said, hey, look, we'll take some risk on payment around bundles of, joint replacement or or any of the other things. And we'll take on the responsibility of the risk for actually adding design into the mix. And when we know that it produces a better outcome, we get rewarded for it. It gets bundled into the broader effort, but it takes a courageous institution like the one at Dell Medical School to actually take that leap of faith. And I think what most people remark when they come and see our space is that you could only do this under the business model that you're in. We're like, exactly, right? And so the business model actually incentivizes the aggregation of design into clinical science and all the other things that we do. I think in time we'll get to a more quantitative measure of the qualitative value that design has, but it's a challenge I would sort of issue to all of you is how do you create that evidence? Because in a traditionally evidence-based field, like that's one of the things that's going to resonate most greatly. Thanks for the question.
Time for one last question. Okay.
Hi, thank you for your talk. It was great. In the kind of towards the beginning, when you had that wheel up there of the healthcare, you mentioned that it needs to go from siloed to integrated. Could you touch on that some more and kind of talk about what that would look like?
Yeah, I could talk for another hour on that, but I don't think we have the time. I'll give you one example. Actually, on one of the previous slides on health management, there's this box that said data quandary, right? And that's actually not an IT issue. We were talking about the difference, the collision between what the system wants and what the individual patient wants. And so in healthcare, by law, you're required to share the patient's information with the next institution that's going to care for them, even if you're competitors, right? And the way we do that traditionally now is we print out a giant 40-page sheaf of paper, hand it to the patient. It's their electronic medical record. It's electronic, but we give it to them paper. Then we issue them some verbal directions, and then we give it to them, and then they are the conduit to the next provider. The next provider receives that sheaf of paper, certainly doesn't have time or interest in reading all of it, and then doubts what the patient has to say because they don't believe they actually know what the previous physician was actually intending. So we end up with this data quandary where the patients are the only available conduit for that information, and then we distrust their ability to actually convey it. And so those are huge issues, right, that are built from the siloed competitive incentives that the industry has. That's just one of myriad examples, right? The lack of exchange between social services and healthcare, the lack of coordination between, financial institutions and care institutions. It goes on and on and on and on. And there's a lot of convenient excuses for why we don't do it. But if you actually view the patient as the center of the beneficiary, as the beneficiary of all of that, there's no reason we shouldn't, right? And that's the big shift you have to make.
Stacey, thank you. That's wonderful. That's great.